Radium-223 is a different kind of drug. This is given primarily in our nuclear medicine department or by a radiation oncologist. It's a radioactive therapy. I don't have a nuclear regulatory license to give it, but many of my patients, I'm going to refer to them, to my colleagues in nuclear medicine or radiation oncology to administer this. There are a few key things to know about that. One, because it's radioactive, it has to be handled in a certain facility that can manage that. Two, we have to follow appropriate safety guidelines around that. But importantly for patients to realize is that this doesn't carry with it the same kind of external radiation exposure risk that, say, other forms of radiation might. And the reason for that is because this is an alpha particle. And radioactive alpha particles have very, very limited penetrance, literally stopped by a piece of paper. And in your own body, in your own bones, where it's going to deposit and release its radiation, there's essentially no risk of radiation exposure to anybody around you. So that's really important for people to know. Certainly, it's cleared from your body, and when it's cleared from your body, it's primarily cleared through your feces. So, but just normal hygiene and can take care of any of those particular risks. So, by and large, this is very safe to administer. It needs to be administered in a properly licensed facility by credentialed and licensed physicians, but has been very well tolerated in our patient population. It really doesn't expose them to risk outside of their intravenous injection. In the ALSYMPCA study, which was the pivotal trial that led to the radium approval, patients were treated with either radium or placebo, and the population of patients included symptomatic patients who had either refused chemotherapy or were chemotherapy ineligible or had previously been treated with chemotherapy. In those populations of patients, and at the time the study was done, patients were allowed to have best supportive care. However, abiraterone and enzalutamide were not widely available as best supportive care at the time. So patients got other secondary hormonal therapies, things like flutamide or bicalutamide or ketoconazole as secondary hormonal therapies. And with those, patients still tolerated radium-223 well and were able to demonstrate a survival benefit over placebo with a hazard ratio of about 0.7, so about a 30% improvement in the risk of death associated with treatment with radium-223 times 6 doses. So in my mind, although abiraterone and enzalutamide were not available at the time, similar mechanism drugs were and were allowed, and in our own experience, we've been able to see good tolerance and disease control associated with that combination. Radium-223 has essentially kind of two sets of side effects. One are the marrow side effects, so causing cytopenias, things like anemia, thrombocytopenia, neutropenia, lymphopenia. By and large, these are rare and transient, the most common one being the anemia associated with it. But the later we use radium, particularly after chemotherapy and in patients with large tumor burdens or that have undergone a lot of external beam radiation to other bony sites, the more cytopenias we see. So in my experience, we've been able to see less of those when we've done that early. The other set of side effects we see are GI side effects, things like some diarrhea, some upset stomach, or what have you. And that's partly because the drug is cleared through the GI tract. Now, when we start to combine this drug with hormonal therapies like abiraterone or enzalutamide, we can start to see maybe a little bit more fatigue associated with the drug, and that's probably a mechanism due to both some of the cytopenia changes as well as the fact that our hormonal therapies result in fatigue. So we do see a little bit of overlapping toxicity there. But I would say, since fatigue is not a major symptom associated with radium, most of that's been attributable to our hormonal therapy and something that's been very well managed. So for the most part, there hasn't been a dose-limiting toxicity when we've administered these agents early. Where we see them becoming more dose-limiting and difficult is in our later stage, heavily pretreated patients with a high tumor burden. It's really important to recognize that the benefits associated with radium are with serial dosing. A single dose is unlikely to replicate the same survival benefit that we see in the ALSYMPCA study, versus a patient that's able to tolerate all 6 doses. So for us, it's really important when we're thinking about a course of radium to think about it both in terms of being able to get through that sort of 5-6 month period of time where they would get exposed to radium and live long enough to benefit from that. And so again, we're looking at patient populations earlier. When you do that, that's where radium starts to overlap with other therapies that are indicated in that space. And one of the really great things that we've found in our experience with radium is that it's been able to be well tolerated with other agents. There's no drug-drug interaction risks with radium. It's not metabolized through the liver, doesn't affect liver enzymes that metabolize other drugs. It's not a problem in our patients that have slight renal impairment because most of the clearance is through the GI tract. So for us, the big advantages of using radium have been its ability to combine well with other agents and our ability to use it earlier in the disease state. The hardest thing is finding the right patients because of the label that's associated with symptomatic bone metastatic disease. And in my mind, symptomatic doesn't mean severe symptoms, it can mean mild symptoms. And recognizing that there's more symptomatic disease than just bone pain. Other symptoms like fatigue, loss of appetite, weight loss, decreased functional status and mobility, and even things like lethargy and weakness and some neuropathies can be also associated with this disease. So recognizing that symptomatic metastatic castrate-resistant prostate cancer is a broad label, not a very narrow label, is really important to recognizing where this drug can be used in our armamentarium.